they cannot make. Okay, thank you so much. So I'm going to share some slides. I'm going to then open up. I think Manoj Jain is here, and so later I think Suresh Anne and Chandrasekhar, who are working with me, they will join sometime. So I'll go ahead and present my presentation. Let me share the screen. Before I, okay. So this is we've been doing, as Anupama Garu said, Suresh and Chandrasekhar, and last after we did our webinars, so many, I moderated 50 of them more last year. And I thought about, well, why don't I put a Zoom and start seeing patients at evening? So we come home and 9 to 10, 11, and Suresh joined, Chandrasekhar Garu started his Zoom link. So we're doing continuously since then till now, and major burden is taken by Dr. Suresh Anne. So then we came to this, we learned that here in USA, the steroids high dose is not allowed protocols wise. But I came to know that back home in southern state, Andhra Pradesh, youngsters started giving higher doses, and they're able to subdue the cytokine storm. So I took 2 cases and presented, and it is published as a case reports in Curious in December. This is the presentation. So we, at the time, we went to the Andhra Pradesh task force. We represented to them, presented them, sir, is steroids working? Because first webinar we did with Dr. Maduri. Maduri is a professor in pulmonary ARDS for a very highly respected in pulmonary specialty. And he said, this is the word he said, if the steroid cost is $1,000, this pandemic would not be a pandemic. So that's what I'm understanding. I'm not going to quote, but because it is not used as it's supposed to. That's personal opinion, nothing to do with anyone. So anyhow, let's going back to, they started giving, we're learning from the back home. They are giving 250, 500, and then they're responding and we're listening to them. Then after that, I looked back and learned where are the cases we give high dose steroids. I learned when I was in resident in 85, Johns Hopkins did pulse therapy for rheumatoid arthritis, 1,000 milligrams, 5 days. We used to admit the patient, we follow the protocols for 3-4 days. Then multiple sclerosis, those give steroids high dose 3-4 days, pulse therapy is standard given even today. And the irony is children, multi-system by COVID, same hospital, even in United States, same hospital, a child gets steroid of 10 milligram per kilo in the ICU, but an adult have 40 milligrams. I can't imagine what is the difference, and why don't, my question is, I may be a single doctor, but why don't the academics look at this issue and do the study? Let me go back and come back to the issue of the main thing. So COVID-19, what is the course? See, we have, this is very important. This is very, COVID course is 1 to 14. When does the cytokine start? It is second week, 5th to 12th day, 5th to 12th or 14th day. So second week is too late. So we have to hold it first week. So when do the patient come? They have fever, they have the cough, and by the third day they come to see you. So instead of RT-PCR now, I'm doing CRP. If the CRP is high, I'm going with the steroids. I'll show you a few cases. And we need early intervention. So the CRP is the key here. When I'm going to summarize the whole thing early, and then I'll go back again. In the steroid dose oral are mostly, most of them is oral tablets, almost 90%, 10% needed high dose intravenous. So what we are doing is we're doing either 16 milligram methylprednisolone twice a day or 32 twice a day, usually for a week, and then we go into half the dose another week. 2 weeks, 3 weeks, they will tapering off. But normal CRP, majority of the labs in India is of 5, and we monitoring along CRP and pulse ox together. We know the CRP rises 3 days before the pulse ox. I will show you 2-3 examples that pulse ox never dropped, and the CRP is way high. And if I don't know any studies, I haven't looked clearly about the CRP, looking into the pulse ox combination and outpatient wise. I have not seen recently. I mean, I have not researched yet. So what is we're giving? This is the dose we're giving. The CRP rising, this is 125 milligram twice a day, 250 milligram twice a day. Rarely I'm going to 500. And tapering dose after 3 days, we'll get the half, and then half, and probably 3 weeks to take them completely off them. Or sometimes we have some people are up to 6 weeks. It's still 6 weeks of steroids on the course of, with our experience, is not long when we're saying so many people. So home treatment, COVID-19, how to reduce hospital admission. How many is the admissions? Like I looked into our county, is around 7% to 10% hospital admissions are, so if you take a cases, 7 to 10% are admitted. That's the ESA statistics. And I'm sure they're pretty close, same in any part of the world. But we are about to publish. We took our outpatient. We have done not IV, 275 patients. We have maybe 1% admitted. This is in USA. This is retrospective observational. We took a IRB permission from Western Michigan School of Medicine, but we kind of delayed with all the work, and we're about to publish. So that admission, 1% to 7. If you follow the same protocol, even with the oral steroids earlier, I'm sure we can reduce a lot more. The dose what we found in India, when they give only 5 days, a small dose, and they don't follow up higher and then manage. That's where the gap we found. If monitor from day one symptoms, that's the most important, day one of the symptoms, and follow the CRP and pulse ox after 6-minute walk. We thought this is the gold standard, yes, but now the CRP is more earlier if we can afford. And also, I have a patient come with high weight, like 100 kilos, then I know that patient is going to be. So anyone, we already know comorbidities. We know the diabetes, we know the elderly age, we know the male, we know the overweight, younger people are comorbid, and they are the ones you can really, really closely monitor. If you have no resources, at least measure CRP into those them. And then we stop with inflammatory condition. So this is an example I was told, a small village back in India. This data came a few days ago, and currently is going on. Out of 200,000 people, 45 patients are positive symptomatic, positive. Out of them, we want to know what is the pulse ox, how do we measure? So we took one of the COVID patient, go and take the pulse ox of other place. So he took it around and got the data. 5 patients are 90% or lower. So if you take that, and also weight is 10% or 80 kilos or higher, so 200 pounds. So what is this means? What is the reflect across the India? We're talking about 2.5 or 3 million people sitting there, pulse ox 90, maybe not knowing. And that is the thing what we're dealing with, or even more. And they have no cases, and there are no beds for these people, no oxygen for these people. They have the whole village are 2 pulse oximeters, but that's good enough. I can solve the problem. They do not even know where they have a hypoxia. That is a sad thing. So how many make it? How many doesn't make it? I have no idea. So let's go back on the CRP, and normal level is 5. So most of the patients we're looking at the beginning 5, and then we are noting the pulse ox is between 80 to 90. Most of the hospitals, I'm sure you all see CRP level between 100, 120. I don't think you ever saw CRP, maybe a few cases, but you don't come up with less CRP when you hospitalize a patient with hypoxia. And I would like to open and take the information and learn from everybody here. CRP can be elevated in many conditions, but this, I think personally, this is one thing we can follow, at least to guide. And let me go, this is, this patient is 57-year-old, I'm following currently. This is live data, April 22nd, she has symptoms. And now today is 12th day of symptoms. And by the time I started around, I debating to start or not, minor symptoms. Then the CRP came in 22nd. I think then I told them immediately, and then we started 32 milligram twice a day. Out of 32 milligram twice a day, look at the CRP on the 27th, 5 days later, it down to 5.8 and 3.5. Today is 11. There is no cytokine. Probably she's a woman rather man. The weight is reasonable, nothing. So that is what we saw. And her pulse ox remain 98, 95. We never worried about that. So next go. This is the case, similar family. And I think 48-year-old, 110 kilos, diabetic. And I think it's April 22nd started, similar day, a day, same thing. 12th day of symptoms. Look at the CRP at the 24th is 14, actually a little bit lower than other. And we started 32, 12. And then it became 20. So when you're giving steroids, instead of other cases went down, this went up 20 up. So with this risk, I have, and it's coming more and more into the cytokine storm. And then we went to 250 twice a day. So it went down, again, it went up. So then what we did is we did give one 500, but today report, so it's coming back to 20. I'm going to stick with 250, and then I'm going after 2 days, 3 days, we're going to go down the level. This another patient where I was behind because in this group of the family, they did not post these numbers for me. They delayed 2 days, and start of symptoms is 25th April. They started 45 milligram twice a day. Eighth day. Now today is eighth day. That's currently going on. Pulse ox is 95, 95. It never dropped much even today. CRP level April 29th is 15. Okay, it's higher. In the May 1st, I didn't is 30. And then today, after giving 250, I was rolled 50. So this normal patient, 102 kilos, and we're in the eighth. So everybody worried about anybody who's treating the COVID. Second week, early second week is the most one. If by the end of the second week, we can take a deep breath. And this is the early stage. And 50, I gave 250. I told them tomorrow give 500 because this is I'm very worried about this patient. I think in this case we're 3 days behind. So let me go back. So this is common information. Elevation first few days, and later is the pulse ox coming, and we need to act when CRP rises. We need to measure CRP daily, can detect patient early, and a higher steroid, you can tighter like a sliding scale of insulin. So how about the glucose level? Yes, we have to measure when the patient, this is the patient, and realistically, when they go home, you don't find anybody going to their houses. It's very hard. When they go home, when they put the glucose, they check the glucose level, they check give the insulin appropriately, and they get the lab done. And that's what they're doing. And we check with the top endocrinologists. They do the glucose, all the COVID hospital check 3 times before meals, and they short acting insulin on a sliding scale basis, and also sodium, potassium, because they measure that so that it can be given. Side effects. Yes, there are side effects. There are case reports of fungal pneumonitis. There are cases of mucor. What I learned is, I'm sure other specialists can give the numbers. I don't know. What we learned is most of the studies, one of the study we said all of them in the hospital, oxygen, they have the face mask. So the fungus is coming. And then maybe after we may have to follow these people after the high dose steroid given, weekly cultures, and then see maybe early prevention intervention to prevent this. But there is a risk versus benefit, which experts like to weigh in and help this situation. So this is the oral medicine. What we are doing is essential medicines. Mostly we're doing methylprednisolone. In India, everybody giving methyl or any steroid, but the dose is 8 milligram twice a day. They're not escalating. Anticoagulants, of course, that's standard. Others we give famotidine, vitamin D or magnesium. Rest of them like ivermectin, Fabiplu, antiviral, we have not need to give in. And when we, like Dr. Anupama mentioned, that we do the Zoom call almost like 2 hours a day, and all our outpatients from last 8 months, we rarely had admissions. Very few often really needed IV steroids at home. And when we start the oral earlier, I have a feeling that need for IV will be lesser. So I'm going to present some names of this. There are so many names like Predmed, Deslone, Nucart, Visalin is by Vaithuka Pharmacy, Defcort is other steroid, and Acticort, Prednisolone, these Ramnicort. There, I have a feeling that several companies are making, and we try to find out is there any short supply, because last week I concerned about it. And I mean, I'm from AP, we talked to Hyderabad. In India, what we learned is for last 15 years, no new company filed for a license for steroids. Probably there's enough, or maybe there's no incentive much. So no, there's not much need. So what looks like there is enough supply, or we don't know. We wanted to write from RP's draft written so that at least to get attention, look at the supplies, look at needed, make sure we never want to be short supply. That's what we're requesting through the RP. This is the small brief summary. We said COVID-19 pandemic only medication shown reduce mortality, early recovery is such as these medications, IV steroids. The second wave, many patients needed these essential medicine. We from RP reaching to you all manufactured in India and around the world to help us. Want to make sure, I don't know, there are under short supply, there are enough. When we want to buy for our outpatient, we are hard paying IV medication. We're not getting it. Hospitals have it, but outpatient is very difficult for us. How to implement? If the same practical, what we did on the Zoom meeting, what we did on the realistically, the government can adopt. They have a system. So the same implementation, they can have their outpatient clinic, give the permission for the outpatient doctor. They can, if my cytokine, my CRP is 30, I go there in the morning, get all this done. In the evening, I come back and do that. Like here, we do the test like a drive-by, or some clinics, they give that. So that can be reduced, I think 90% with this protocol. We can stop this. That's our opinion. And this is not today's. This one we recommended even before. It did not take up. We presented to Andhra Pradesh government task force in June 2020. Me and Suresh was there, and they took up the steroids given IV, but they never took up the oral because there is no ISMR instruction. There is no anyone, so nobody want to take them themselves. But the task force doctor really took up on social media, given 40 milligram steroid for 1 week across the state. And there are manufacturers. I'll stop here, and then we want this as discussion, and just get this information out, because a lot of people want to do telemedicine, but the question is telemedicine, what do you want to tell them? What is the reality? Do you know all this information? So you may know everything or more. I like to learn from you, or if any gaps, I need advice. As I mean, we all need to work, see, go from there. I'll go ahead and stop my screen.
Thank you, Dr. Idara, for giving us the data and your experience using steroids in the early phase of the disease. And this is very educational for rest of us. And Dr. Suresh Ani, is he here in this conference call? If he has any experiences, then we can go ahead with the questions. And Dr. Amit Chakravarti will moderate the Q&A session.
Suresh, are you there?
Yes, I'm here.
Go ahead, Suresh, please. Thank you so much for coming in short notice.
Good evening, everyone. I think the main concern that we have is how to deal with this pandemic. I mean, we all discuss about different drugs that can control or that can reverse the inflammatory reaction. If you see the massive scale of spread of disease, we don't prepare. We're absolutely not prepared for even basics to give to these people. We can discuss hours and hours and hours how we have to use anti-cytokines, how we can use the cytokine filters, how we can use whether this drug is effective or not on the antiviral drugs. No matter how much we discuss, I think we need to go and sit on the practicality. What is that we are doing with the rural India? What is that we are doing the poor of India that can't even get access to see a physician or even a nurse in that situation? I mean, how are we going to deal with it? And that is a question I think we all have to ask ourselves. How we are going to reach this last mile that can address the major issue that is hitting the heart of India. I think when we question it, what are we going to do with, yes, somebody proved that cytokines are the one that is causing the problem. You need to use the anti-cytokines. How many people are you going to supply with the anti-cytokine antibodies? And forget about whether that works or not. I'm not concerned about it. Even if it works, how many people that you can supply? Now you say how the remdesivir is in the market. It is in the black market, working about at least 1 lakh rupees for a dose for the drug that does even remotely, even questionably, that is helpful to prevent the death. So why are we really struggling this? And I'm seeing this in all the groups and webs and talking about back and forth, what are the complications, how we have to address, how finally you can treat it. I can understand there is enough of manpower, the intelligence power in India that can deal with those patients that are in the hospital. They are struggling. Even if you see those people that are in the hospital that are dealing with the day in and now they're burnt out. So we're not here to give them what is the most very effective way of controlling without any side effects. No, that is not. They are all very well versed about the disease. The problem is now how we are going to reach the bottom of the bottom in India how we can save these people, or at least to help them to be comfortable. So we talk about it every day. We have been seeing this for the whole year. It's not one day. We have been working on this project for almost last July or August. And it's really painful to see these patients can't even get a hold of a physician, even by phone. People that are sitting outside the hospital, not even administrator come and see them. There are people dying in the hospital outside. So how are we going to reach it? We're just ignoring. We're just looking at as if nothing is happening there. I think that is a concern that the Lokesh really had it, and we are having really discussion with the thought leaders there, with the political leaders there. Those who want to do, the question is how. I mean, the same situation came in the last year, but luckily that's not as worse as now. At that time only, we did address about many groups. Watch for the second wave. Watch this. This is India is not prepared at a massive scale of this disease that is spread. So with that goal, what Lokesh was doing is we were doing is even training is NMs, even some technicians to help. What is the minimum that we can do? What is that easily that can available for us? After all, we can't even get this minimum oxygen to the people that are suffering there. That is the saddest part that we have. So in this condition, we see, actually, I told people, families, I told them, if you want to stay home, the chances of living is 200% more than when you go and admit in the hospital or in the infant of the hospital. Or if we can't save you, if you are going to die, you have a dignified death in the house. Think about it ourselves, each one of us, just look into ourselves. What are we doing? We are giving expert opinions, throwing about everywhere, but nobody addressing how to reach this population that is just left alone. This is about 60% of the population in India in the dire situation. So that's a massive scale. How are you going to how are you going to train a trainee, a local volunteer to go and identify their cytokine levels, how identify that who is wanted the steroids, who is wanted high dose, who wanted loading? Impossible. So the simplest way is to prevent it as soon as possible so that they will be comfortable. If they survive, they definitely survive. The chances of survive with that protocol that what Lokesh is proposing, and the chances of dying a dignified death is a lot better than dying in the hospital without even any family member there. If anybody suffer in this family, in this group, 1 second, Rakesh.
Oh yeah.
I'm the one that is affected, probably the first person in this locality, in my locality, to lose a family member. I know how hard it is seeing a person struggling for breath and lying down. So, well, number two. Second point that I want to mention is, what is that we are worried about by treating with early dose steroids? What is that? Is it viremia? Is it what? Do enough? I can challenge anyone of in this group that they can tell me one patient that died with viremia in this disease. Anyone in millions of people that are involved, not even one single death that died with viremia. I can bet you on that. I can prove it. Number two, how many people are dying with the bacterial pneumonia even after treating, even in the hospital when you're treating with the steroids? Very few, 10% of the people that severely infected has a bacterial pneumonia and dying. Most of them die because of the macrovascular disease, microvascular complications. So why are we worrying about giving them steroids that can prevent the inflammation? Every one of us know this is the inflammation that is killing these people, everyone. But when it comes to the practicality, we forget about treating it early, simply. And third one is, what are the complications that we are going to get from the steroids using early? Very minimum dose of steroid, 1 milligram of steroid of 1 week. I have been practicing here in this country for 30 years. Every day we treat people with steroids without monitoring for asthma, acute exacerbation of asthma, or other diseases that we know we see. All these diseases we are treating with the steroid the minute the patient calls you, or we give some of them steroids to take it at home whenever the complication, whenever this problem, acute exacerbation comes in, call me, call it. That is what exactly we preach here. And how many people that have the COPD or asthma that is exacerbated by the flu or influenza or viral disease treated with steroids? We treat every day. Do you see any complications? Do you see anybody dying with a viral pneumonia? So I think that that's the background. We strongly recommend that these masses of people, the simple drug, easy drug, yes, we want to err on the side, so prevent the complications. Even if we err on the side, the complications are not significant. They're minimal when compared to the devastation that this disease is causing at this time. I think I want every one of us look into
Thank you.
ourselves, see how we are going to
Okay.
address this issue. Sorry
Thank you.
for it.
Thank you, Dr. Ani. I think we heard about how you are stressing steroids are important in the early disease. So we're going to go with the question and answers. Dr. Amit Chakravarti will moderate the session. Q&A.
One first.
And there is
Sorry, go
a
ahead.
Jain who raised his hand. Vijaya Kodali, can you mute Dr. Manoj Jain?
Manoj Jain. Dr. Manoj Jain is infectious disease specialist. A lot of work he did in India, has communicated with the government of India, so many levels. Dr. Jain, thank you so much, sir, for coming, and please help us.
Sure. So, Dr. Lokesh, thank you so much. And Dr. Suresh, thank you so much for your comments. I think the real question at hand, I'm an infectious disease doctor in Memphis, Tennessee, and I also worked very closely with Dr. Maduri. In fact, I spoke with him this afternoon, Lokesh, after our conversation.
Oh, thanks. Thank you.
And Dr. Hiran Pokarna is infectious disease doctor with me here in Memphis. So I think the real question at hand is the following. There is no doubt in our minds as ID doctors and as general, I think, physicians who are following and caring for COVID patients that we need to give them steroids. What we are really, and there is now evidence. So really talking about there is clear evidence-based treatment for using steroids. The question at hand is using what Dr. Lokesh is talking about is high dose and following this protocol of looking at CRP and hypoxia and going to a higher and higher dose as needed. Unfortunately, the science has not caught up with the preliminary findings that Lokesh and others have been seeing. And the question at hand is, with our clinical experience and what we know, should we begin to push this idea? Because if you did a randomized controlled trial on this, it will take 6 months, a year or more, and we don't have that time. And I think it's going to depend on the level of comfort of the doctor and the patient. I am by far more convinced than I was before, especially after talking to Lokesh and looking at some of his, and I'm happy that API is moving the idea and agenda further. And what I think we need to do is to have these fair conversations with our patients and with other colleagues. And until we have that evidence before us, we have to say we don't have a randomized controlled trial to prove this. However, enough evidence is there that I, as a doctor, believe that it will be beneficial to up your steroids to be this level to try to do this. And that's how I would approach it. I think this is very provocative work that you've done, Lokesh, and very helpful. And I think we should move it forward and share it with others.
The other thing I said is last year before Dr. Maduri's talk, we said the biggest pandemic. I changed that first 4 weeks my wording. Biggest mistake of the pandemic, not starting the early steroids. Then I added that high enough and long enough. Long enough means every study do 3 days, 10 days. This inflammation is 4 to 6 weeks, and we know 6 months. And who will correct mind do the 3 days and then close the deal? So the biggest pandemic, I stay my word, biggest pandemic, which would have saved millions of people, millions of lives, not starting early steroids, not high enough, not long enough. And high enough is not the first one. 50 years, they given the pulse steroid 1 gram a day for 5 days in America with no infections, with nothing. which is nothing risk versus benefit. Early steroid, I'm an asthmatologist. Out of 6,000 people starting 1 year to 90-year-old, early viral infection, 60 milligrams a day for 5 days, long enough. Any multivascular inflammation, 6 to 8 weeks. These are 3 well proven. It is evidence there. So I'll stop here. I'll take other question with them.
Thank you so much.
May I say one word about it? I'm really thank you, Dr. Jain, for talking to Dr. Maduri. I think in this platform, when I was first time, Dr. Maduri and myself, we talked about the steroids. That was in the April of 2020. And we were, since then, I mean, I'm glad, I'm really thankful for you to talk to the first-hand person that we deal with. And this is the problem we're talking about, this high dose steroids. Everybody will talk about, I mean, these patients otherwise are left alone. I mean, that is a small percentage of the people that needed this high dose steroid. Majority of them, they do fine with the low dose steroids. We're seeing it time and again and again and again. Our patients we treat as an ambulatory care. Everyone, of course, here I have an access to everybody. But in India, where we are facing now, there is no access. So how we are going to deal with it? So who is going to follow up it? Thank you for your first-hand information from directly talking to Dr. Maduri, who is the pioneer in this research. Remember, we don't have any. One sentence. We talk about all the time the evidence-based medicine. I do not have a one iota of evidence that the steroids are causing any long-term side effects or in these patients that are causing the death. I have not seen one study that the steroids are causing the deaths, increasing the death.
Okay. With Dr. Vithal sir, can you unmute and ask the question? Oh, sorry.
Amit Chakravarti.
So thank you so much, Lokesh. Lokesh, as you know, is a man with a passion, man with a mission, and and has saved several lives. And the dedication with Lokesh and Suresh and Dr. Koneru have done for the last 8 months is commendable. They have religiously done. I'm sure Anupama has told you earlier. Religiously for 2 hours, they've talked every night to patients in India directly. So that's hats off to them, commendable. There are several questions. And I also thank you, Dr. Manoj Jain. People who don't know about Dr. Jain not only is a great ID doctor, he actually was in the Memphis City task force for COVID guidelines when it started. So he's a big shot in Memphis. The questions which we have is, there are questions about, hey, listen, are you talking about CRP every day as an outpatient in India? They are casting their doubts about the feasibility of that happening to the regular Indian population.
Okay, that's a very good question. Yes, CRP is at least available. It is the cheapest test. And can it available in the rural area that's we're facing? We don't know. If the government takes initiative, it can be done in 2 weeks. It can stop 80% of admission. I mean, if the government take the ownership, they have lakhs of health volunteers. They have CRP labs. A village have 2 people. Okay, they follow this. They check that. Okay, this is done. They can put in outpatient in the same town. They have primary health center. They have glucose, everything they can set up. Government has to own it to stop it. Of course we do. Of course we do. Very few. It has to be taken ownership. Let me explain this. They have given. Government of India has given permission without the release of 3rd phase of Covaxin results authorization. Fabiflu never given in America is authorization given, which antiviral never works. The ivermectin is there going everywhere. So steroid is saved. There is a new study came out, early inhaler helps. The studies there later works. There's the middle one have experience. If they give emergency authorization, leave the whole thing out, they will close the deal in 2 weeks.
So the answer is that though it is a difficult thing to get in rural villages, if government takes that as a policy,
yes,
that can easily be implemented.
Yes.
Thank you so much.
If you go and do yourself, if they don't like it, they can make anything against you. So you have to work with them without permission. You cannot move. So there is a simple solution here, which is overlooked. That's our pain.
Dr.
Great. Yes.
For the question that you asked, You don't, if it is not available, you don't have to do it every day. You can do it every 3 days. You can do it, once every other day, once in 3 days. It's depending on, now we have to adapt to every situation that we can get to face. We have to adapt. Otherwise, we will not survive.
You can do high
Adaptability
comorbid,
is good.
100 people or something like that. CRP.
Yeah, I mean, so that kind of sums up both aspects. One, that yes, if government steps in, that can be available. And the other aspect, Dr. Anne says that if you cannot do it every day, try to do it every third day or every fifth day, and that is perfectly fine. So the other, go ahead. The other question, we have got plenty of questions, so I need to move forward. The other question is that what SATs are we looking for starting steroids if CRP is not an option?
Well, I thought about before pulse oxis before. With this thing I experienced last few days, I can able to stop it before the oxygen. All my patients are 95 and don't need oxygen, and they're sitting home, both low risk patient, high risk patients so far. But I'm sure I can present a week or two what more I need. These are earlier, they can afford. This model we're going through.
Dr. Chakravarti, the one other thing that I want to add here is, even before, if you have symptoms, even if you have the cough, you have the fever, treating 1 week of steroid just is really not going to cause any problem. If you start about 0.5 milligrams per kg or 20 to 40 milligrams a day, it's not going to cause harm. It prevents a lot of people getting into the storm. So
yes. Our study, me, Suresh, and other, we have retrospective. One doctor in Texas used to give everybody stuff he knows, like 40 milligram prednisone for a week. So we never seen any. They're fine. And what we're saying, viral issue and other things, they're all better. They're nothing. None of them in the hospital. So there is no viral issue. They better. They're not going wrong.
One more thing, Rakesh, I want to add this one, Chakravarti. It's very, very important for everybody. In this study, we've seen it is in the final preparation. If you start the oral steroids before the 3rd day of the symptom, that means once you get the symptoms, and the 3rd day, if you take this, treated to the patient steroids before 3rd day, after the symptoms, the steroid dose that they require to prevent the hospitalization is half. It's only half of the dose that we use. And the patients, if you start after 3rd day, why we pick the 3rd day? The patients have a prodromal phase of 3 days. And then when you have the symptoms, they have 3 days of symptoms, that's a 6 days. That is viral phase is almost at the end of the stage. So we looked into them whether if you first day when we treat the patient and second day that calculated the dose of the steroid, the earlier that you start, the less dose of steroids that we used.
Got you. Thank you so much. So another question we have is that is there any difference or benefit with dexamethasone versus methylprednisolone?
Absolutely no. You grab any steroid that is available. We have treated with the Visalone, we have treated with the prednisone, we have treated with the dexamethasone, or we have treated with the Solumetrol. So you grab anything, just make sure that it's a dose that is.
There is a if you Google steroid calculator, it will come. You can put what medicine dose calculator, it will come in 2 seconds. You can use that when you're doing telehealth. So this one information we're trying to, you're all experts, you know everything, but if any gaps we want to present to you when you're talking to your doctors across the patients across the country in telehealth. That's what I think. Dr. Vittal is a raised hand. Sorry, unmute, sir. Yeah, go ahead. Unmute, sir.
Yeah, this is Dr. Vittal from Atlanta, Georgia. I'm a gastroenterologist. Thank you all for arranging this Zoom webinar at such early, very timely. I really thank Opi and Dr. Sudhakar, by the way, sent an email to contribute, and we all contributed towards the, oxygen supply in India. My question to Dr. Suresh, is the prednisone supply, enough supply in India? And number 2, how hard it is to start CRP test in small towns?
Sir, number one, we are facing now a little bit of availability issue with the different kind of steroids. But if you decide whatever the kind of steroid that is available, if you're converting and using, we're still getting it. And that Lokesh is also talking to the government, see how we can streamline the supply of the oral steroids as much as possible. And the second question, I'm sorry, I lost the second question.
How hard it is to do CRP test
monitoring
in
CRP,
small towns?
Again, we are not dealing with the steroid. We're not depending on the CRP alone. Yes, I understand. If it is available, we'll do it. If it is not available, we'll assume it and treat it. Just like in the asthma, we're treating it, asthma exacerbation, we treat it for 5 days, 10 days. If it's symptomatically improving, then forget about it. If you're not improving, you proceed further. And people, wherever that you can get the CRP, will get the CRP. If we're not, we're living with it. I mean, what else? What other option we have? Tell us outside.
Okay.
To add Suresh's note, see, most of the people, like in America, when we do the Zoom, our own patients, they are, see, we don't depend on CRP. They give 80 milligram, they're fine. But the 10% comorbid patient, they are the ones, the CRP, I want to get them earlier than hypoxia, 3 days before, then I can knock it down, I can stop the cytokine. That's why I put my heading so-called today, how to stop the cytokine storm. See, those 10 patients who are in the hospital, how do I early get them and how to hold off to them and then prevent them? So that's where the whole crisis coming in. The rest of the 90%, they will survive. That's not the issue. Thank you. Next question.
Okay. The question, the follow-up.
Dr. Chakravarti,
yes,
one
sir.
second. I'm seeing two important questions that are coming up in the screen. Let me address that. So I think this is the problem that everybody has in their minds. There are two issues. One is they're questioning about the dexamethasone study, which is Oxford study, that is saying at least those steroids that are causing the death rate increasing about point, probably a tendency of increasing it. Let me address it and give you 1 minute to address this issue. I think that is the biggest mistake that they have done is they say that it is a tendency that is showing increase in the death rate in patients who have steroids used without any hypoxemia. And they have no data there. Number one, it is same as placebo. There is no statistical difference between the increased that are with the steroid or without steroid. That's number one. I want you to understand that there is no statistical difference between those two groups if you use the steroids early before the hypoxemia. That is number one. Number two, that study, they started the steroid, the early dose steroid started on day 2 or day 2 or day 3. And they stopped it at the 10th day, which is the day that they needed. They needed that day because of the inflammation. So when you're stopping that, everybody is the same. Whether you take the placebo or steroid, you're stopping everybody before the inflammation started. So that's out of question. So both are the same, which is that study supposed to show, which showed it. So that's a question about the steroid early dose effect.
Next
Second
question.
thing, one more time. Second question that I'm seeing constantly here is steroids side effects. It can be hyponatremia, it can be hyperglycemia, it can be the shock. Those are the group that's the diabetes. We know that is a complication of the steroids. The same thing we do in the patients that we're treating with asthma and other diseases. Yes, if they have blood sugar problem, if they have diabetes, they have somebody contacting there. We treat them patients with whatever that complication. The hyponatremia is because of the hyperglycemia. So these patients we already treat. That small population has to be taken care of the more expert than just throwing the steroids. I agree with that, but that has to be done.
Great.
Few questions, Amit, last start together. Dr. Singh answered, is starting steroid when worsening cough or difficulty breathing. This is what we're doing. By the time they are coming, see, if they don't have symptom, they don't come. They have minor, they don't come. They have symptom, they have persistent fever. Those people were giving 40 milligram prednisone 1 week. Okay, go. 90% never need to come back. They're fine. Their fever gone. They're fine. Other 10%, they will come back. We will tell them high comorbid, and of course, and those are the people who take up our CRP levels or pulse oxes. So they are one. The issue now here is reaching these people below 5th day, even to talk, even to give pulse ox, even to symptoms, reaching those 6 days is the issue, the mass issue. That is the issue we're missing. Of course, in America, they left completely out. Forget about America. We can't. Nobody treat outpatient below 5th day. So the second question here, will you start CRP steroid? Is it over 10? So what in these two cases I learned is the lady who treated, they nicely came down. The other ones, it's keep going up. They're comorbids. When they go up, then obviously I'm going to the oral to the IV higher dose. Is a diabetic patient? Yes, I'm sorry.
One more question that I'm seeing it, whether the diabetic patients that they need to be insulin. Yes, I think the steroid-induced hyperglycemia effectively can be treated by insulin, and insulin is very effective. And one of the interesting study that we have seen is in the patients, and just COVID itself, because of the inflammation, you see very high dose of blood sugars. very high level of sugars even without steroids. Forget about steroids. In the COVID, the inflammation itself caused increase in the insulin requirement. And when you treat them with the steroids, the insulin is a definitive drug to control the hyperglycemia in steroid-induced hyperglycemia. I think we all know that, and the diabetologists here, they can tell us how to treat it. Simple thing, insulin is the treatment to go.
Great. I think Dr.
Guruvar Reddy, Mr. Amit, I wanted to unmute. Guruvar Reddy is our, he owns the Sunshine Hospital, our colleague, and he from Hyderabad. You have questions? Go ahead, Guruvar Reddy.
Yeah, good morning, everyone. It's a very timely discussion. I was just referring to somebody's comment on the steroid non-availability of in India. Steroids can be available for the next 100 years in India.
Good.
The reason is there won't be any black market because the pricing is so low.
Okay.
So no black marketer will take it to the next level. So steroids availability is not a problem at all.
Even IV?
Only thing you got to come as a clear-cut guideline, and probably we will disseminate and do that. Because some people, our own pulmonologists, somebody have got an old notion that the premature or a bit of early steroids will create more damage than benefit. So
where is the evidence?
Yeah.
So great, thank you so much. I think what Lokesh is doing, there are a lot of questions. I think it's a better idea, Lokesh and Suresh. Can you can scroll down the questions and answer the ones which have not been answered, so that the important ones which you have to address, because obviously there are so many questions we cannot go over. We just have another 10 minutes to finish. So one good question is that can they develop a point of care test for CRP quickly? We kind of have answered that. Resources are low. A lot of questions are kind of duplicate questions.
Yeah, let me, Dr. Chakravarti, I want to ask one question here. Any issues with the malpractice while prescribing the steroid? I mean, it's an important question that every group I'm seeing it, what option they have at this time in the rural India? There's a legal, we have been doing this for the last 1 year. We have not faced one question about the legality. One person going unhappy. One person is really saying to you, okay, this is it is illegal. What people there at this time are waiting, they just want them to hold their hand, walk with them. That's the most important. If you show a little empathy and a little sympathy, that's what they need at this time. But they want somebody to hear, to take them away. Okay, the fear. I think that's more important. But we all now the legality. There is no time about the discussing or thinking about the legality. I think Dr. Guruvar Reddy can watch for this, the way that they would think, because he's on the ground.
Dr. Guruvar Reddy, do you have a comment on that?
Is here? He might have run. It's early morning.
Okay.
Oh, he's here.
The question is that is there any legality or any legal issues stemming up from early high-dose steroid use?
Sir, there is no legality as far as India is concerned at the moment. It's not there anytime. It is not there at all now. If the patient leaves, that's fine. And no rural patient, even urban patient, is going to sue you that so-and-so has used the steroids early. Because there are many people are using and many people are saying that this is coming up well. That's what I'm saying. If API gives a guideline in like a blue paper, then even if something 1 in million it goes to court, he can produce an authentic body like API that look, these are the guidelines and these are the studies, and so that's it. No legal problem at all.
I think Lokesh, Suresh, and Dr. Koneru can work on something like that.
Thanks. We also want the Dr. Guruvar Reddy Hospital have 100 patients on wait list to admit to his hospital.
Wow.
100 patient wait list for his hospital. I'm sure the same thing goes around the country. That's what I heard.
Thank you so much. Thank you so much. So there's a comment here. Dr. Guruvar Reddy, is there something else you want to say?
No, nothing, sir. I just want to know whether anybody has got this one ventilator treating 2-3 patients with different circuits. Is there any experience?
Oh,
that's not
yes,
part
yes.
of this
Guruvare
discussion.
Let us.
No, Guruvare, I will get the connection and then I have the people
Yeah,
connect
please.
you. I will take
Please.
care of that.
That
Yeah.
will save many more
Not
lives.
deviate.
Okay,
Yeah, I will
thank you.
connect you, Guruvare, for that. And
Thank you.
Dr. Singhvi want to comment? Can you unmute Dr. Ajit Singhvi? Where is this?
And we have Dr. Kamlakar raise the hand. Can
Yeah,
Vijay
go ahead, Dr.
unmute?
Kamalakar. We'll find doctors. Oh, here you go, Dr. Singhvi. Please, go ahead, sir.
Good evening. Very enlightening talk. Thanks, Lokesh and Sureshji and everybody else. I'll just comment briefly. One of my relatives, 85 years old, they call from India. They can't smell. First thing I did is take 20 milligram of prednisone, which she takes for asthma. It's expired in February. I said, don't care for February. And rest is history. The steroids work. I have talked to a lot of people, ICU people here and in India. Three things they say. One, remdesivir doesn't work. Two, plasma kills. Three, don't go to the hospital. and basically, what has been working is prednisone, aspirin, famotidine, zinc, vitamin C, azithromycin, and hydroxychloroquine. Few people take. So prednisone, very good talk. Thank you very much.
Thanks so much, Dr. Singhvi. Dr. Kamal, there is someone said, please send a list of steroids and companies. I think that may be okay. Legally, it's an RP newsletter. What are the available medication to them? We'll do that, sir. We'll send RP letter legally. Kamalakar Rambatla, I think. Amit, you want to ask Kamalakar?
Is Dr. Rambatla on the line? If he wants to ask it, you can go straight away ask. If he's not on the line, I can continue. There's a question. I'm sorry. Okay. There's a question.
Anti-inflammatory action. That's shown in some COVID studies. That's why, and also the steroids and anti-acid too, both combination, we choose that one.
Okay. So fluvoxamine, somebody had a comment that
that's not the topic. We don't
that's
want
not a topic. We'll pass that. This topic is only on steroids. Some people are they're reluctant to start steroids. Still, they're giving ivermectin and doxy. Again, this is not a part of this thing, but if you want to
that is no. I want to clarify that those who want to telehealth, we do not give antivirals. We have not given ivermectin. We have not given Fabiflu. We have not given remdesivir. We have not given plasma unless 2-3 days. That's impossible. And we are not giving Zincovet. We're all allowed. Only the steroids, famotidine, cardio-effective, magnesium, vitamin D. Suresh, anything else?
And anticoagulants.
Anticoagulants, second best. After the medicine, of course, anticoagulants. Those are the 4 things we stick with them. Rest of them, they give it. We don't want to fight with them. But this is all we're going with our thing.
So that was Dr. Shiganesh Paluvoi's question. Next is Avinash Gupta from Mokapi president. He said that in the initial few days, there's viremia and body is making antibodies to fight the virus. Are we doing any harm by giving early steroids, which will suppress immune response?
We already answered 100 times. You give asthma patient when the flare up, do you thought about antiviral? How many people not treated asthma flare up? What is asthma flare up from? Virus. What virus? RNA virus, sister COVID virus. Did you see any virus? And we looked for researchers. We have not found. We're welcome to see your article. You go and submit. Yeah, we'll bring them. We're looking for. We're not found any, sir. This is addressed several times.
Great. Sagar has asked, can we start steroid even if the oxygen saturation is greater than 94%?
Yes.
Perfectly all right.
That's what our goal, especially this comorbid. What is the anticoagulants? The Eliquis is available in USA, India, and also there is Epigat, APIGAT, which is only 30 rupees. And in America, it costs $1,000 a month. That's second issue.
Rivaroxaban.
Yes.
Epaxaban, right?
Epaxaban is the Eliquis and Rivaroxaban is another one. These are the two drugs that are easily available there. And also, I want to add one thing is don't forget about possibly the aspirin or clopidogrel. If they're taking, do not stop it. And if they're not taking, I will add the aspirin if the patients are elder.
And the reason in anticoagulant standard of care, we're not getting the mass works on anticoagulant because somebody have thrombal issues. Some studies are 2% have clots versus 60%. So we want to leave that other level. It is anticoagulant standard, but steroid is the one. See, when you have epithelial damage, when you stop there, it's not going to endothelial. the chance of clot will be not be there. That's why hitting the earlier to prevent everything else. And
All right,
actually,
Great. Great.
Amit,
We
I
got
think,
we
I
got
think,
3 more minutes. A couple of
okay.
questions. Is the 3 more minutes we have.
we can
Very.
close.
I don't know whether. And if you want to pass that, if it is not a part, let me know. Dr. Jaslene asked if there is a role of therapeutic plasmapheresis.
Absolutely
No.
none. Absolutely
None.
none.
So can we have one-word answers right now? The other thing is that if the patient has end-stage renal disease, does that affect the CRP levels? I mean, do we have to take that into consideration?
No, we don't need to, in those patients, we don't even worry about getting the CRP. We treat them clinically.
Yeah.
Yes.
So, Amit, before we close the session, I just wanted to ask one thing from Dr. Idara and Dr. Suresh Ane. So you have 9 months of experience just treating the COVID patients, early COVID at home with steroids, early steroids. You have 9 months of patient data, and you are doing Zoom every day, pretty much 2 to 3 hours. How many of your patients have been admitted in the hospital, not responded to your treatment? That's number thing. Second thing, can you submit all your data and submit to whatever you have done? Like if you have documented anything like how many people had so and so improvement or deterioration or hospitalization, what was your end goal? Like if you have those data, you can submit and we can review them and we can publish in as many journals as we can. Why not? When you are doing an evidence-based medicine which has no research trials or anything done so far, but you have enough data. This is unpublished data, and you are doing wonderful job with your patients. And this was very educational. So we request you to submit these data to as many journals as you can. That's how people will learn in future. If you don't publish your data, nothing is going to go out of these 4 walls. So thank you so much
I agree.
for
I
the
agree.
So summary,
excellent session, educational for everyone.
There's one more request for you, Anupama. Somebody has put early in the chat box that can this recording be available for people who have missed
we'll
it?
send the link. Second is summary. The summary is simple. Everybody with symptomatic methylprednisolone or prednisolone around 40 to 60 milligrams. And if comorbid patient, if you don't have CRP available daily, comorbid at least do them, and you treat the CRP earlier than oxygen, and with IV steroids will help. We are preventing it. That's simple as that. And we probably, as I said, Gurva Reddy said, maybe we'll try to make a small one as a recommendation, but legality, we have to look into what we cannot, this is our personal opinion. Something like that, we have to check with that. The publication, Anupama, I think we are already there because of the busy. Suresh is so overwhelmed.
You're
so
more busy treating.
The retrospective data is there. We're going to bring that.
Yeah, please publish your that's how we can implement it to the rest of the world. So thank you so much for the time. And I saw a record number of people, 175 people attended, more than 180 people actually. And this is very, very educational, and hope it helped all of you. And thank you for your time, and have a good night and good morning in the India. Thanks.
Thank you so much. Appreciate it. Thanks.
Good night. Thank you.
Good night.
All the best.
Thank you.
Thank you.